here's how, if you've never been to one of these, here's how they work. It is absolutely open forum. You can ask any question you want. You can direct the question to an individual on the panel. You can ask it as a generality, and we'll try and assign it to the right person from the panel's perspective. Chime in as you have thoughts. Do not be shy. I don't have to tell this group that. We'll try and move through things. The one rule that I put down for my panel, and I'm just going to make you aware of, is any very specific personal questions that are on the level of how to manage a medical issue. They're going to give the caveat, and I'm going to give it up front. Unless we're your treating physician, everything is talked about in a general sense, because details are important. And if we don't know all the details, we can't give you very specific answers. We'll encourage you on how to work through these things with your physicians. But if you're going to ask something that's very specific, just keep that caveat in mind and decide if you want to take one of us aside separately. Okay? So with those ground rules, we'll open it up for any questions. And then I get to chime in with my own if you guys are too shy. Lou.
Dr. Becker, you mentioned yesterday that spinal cord injury doesn't just affect where the injury was, but the whole length of the cord goes down.
Correct.
Could you explain a little more why that is the case?
Well, I think there's a multifactorial aspect to that. And I don't think they've understood the whole process of that. And there's also a dependency on the age of the individual. For example, if you have a spinal cord injury in a child, you see very commonly an inflammation, an inflammatory response of pretty much the whole spinal cord. Where with a similar type injury in an adult, you generally are very limited to a couple levels of the spinal cord. And we have seen this in inflammatory injuries, we have seen this in traumatic injuries. And so some of the ideas that we think why this is happening, number one, the easiest one is whenever you damage a part of the spinal cord, you destroy a couple tracts. So you destroy axons. The wires I was talking about yesterday, they come from the brain going to the lower part of the spinal cord. If you cut some of them, they lose their way of being supplied with nutrition, and so they start dying back. And so you can kind of see this dieback phenomenon all the way through the spinal cord. And in terms of the inflammatory response, we're still trying to understand why it's more extensive and more than the other people. But I think it's probably going to take us a couple more years to figure this out.
And when you say,
Mm-hmm.
you're making the equivalent of what happened in the cord with the inflammatory response. The inflammatory response is what we can measure. But you're inferring that if the inflammatory response is there, then there is damage happening underneath the cord.
You're correct. In part, this is an assumption, but we know when we take this tissue, I can't really do it in my patients, but again, in the animal, you can see in the areas where there's a lot of inflammatory response, which I can only see on an MRI, but I can see it on a slide. If I take a cut of this tissue, look at it under the microscope, you see how the inflammatory cells move in and see how they destroy tissue, or they carry away tissue. So.
I will make a comment on that, just for a little provoking some thought on it, because Lou's point is an appropriate one in terms of a chicken and egg phenomenon. And when we see two processes coexisting, trying to decide what's causing what is sometimes tricky. The best example is, you guys have heard about these mouse models for multiple sclerosis now for several days. There's an old one called the Tyler's murine encephalitis. It's a viral-induced demyelinating disease in mice that was for how many decades now used as a model for MS. And you'd give the mouse a virus, and 2 weeks later they get sick and they'd be weak, and you'd section their spinal cord and there'd be inflammation and demyelination. And we said, well, this is a good model for MS. No one really looked, they waited till the mice were sick to look at their spinal cords. And then a group in the last 10 years said, well, let's see what happens day 1 after infection, day 2 after, before the mouse is sick. And actually, if you look at the spinal cord, the first thing you see are neurons dying, then you see inflammation. And so this question of, is the inflammation there in response to something, trying to help, and there might be collateral damage or something along those lines, Or is the inflammation the sole problem? I think it's something that is still unanswered. I mean, we still don't know, and I'm curious the thoughts of the panel. In transverse myelitis, is the only bad actor the immune system, or was there something happening in the spinal cord to bring the immune system in, and then in the process of what would have been a normal biologic response cause more damage? I think that's a question that's still out. I don't know, Doug, if you have any.
Yeah, no, I think that's a very good point. But there's probably not one trigger. I think in some cases the inflammation may not be the inciting event, but amplifies and causes bystander damage that was worse than whatever the original thing was. And so we don't know what the triggers are in transverse myelitis in all but a few cases. In a few cases we do. And it may be an infection that gets into the spinal cord or actually triggers the immune system to overreact to the infectious process and starts to injure the nervous system. But then there's kind of this augmenting inflammation that probably worsens things, and that's why we give steroids or plasma exchange or cyclophosphamide or things like that. So I think there are a bunch of things going on.
Next question.
Actually, can I just jump
yeah,
in
please.
with one thing?
Yep.
With patients who have lesions way up here in the neck, you're going to affect the whole spinal cord below because there's only one way the rest of the spinal cord can connect with the brain. Is that one of the questions you were asking? Okay.
Well, I think he was referring to, because I had a slide yesterday where we did a mid-thoracic spinal cord injury, and you could actually show a diaback of tracts and an inflammatory response all the way up to the high cervical and all the way down to the low lumbar. I think this was the question, right? Yeah.
That's what made me think of the question, yeah. But obviously it applies to TM as well. I mean, and when you talk about stem cells, you made the point that the inflammatory environment could cause the stem cells to fail to remyelinate, or could be a good thing. And you also talked about attracting stem cells to the site of inflammation when you're talking about delivery. So it does sound like inflammation is good at times and bad at other times, and that produces unexplained effects that we can't produce in the lab dish, and might be part of the reason why these stem cells aren't working, so it keeps coming up.
Yeah, I think this has been the bane of existence for immunologists for the last 30 years. For every paper that reports an immunologic process that is of harm in one scenario, you'll find a paper that reports the same process as being of benefit in a slightly different scenario. And that's just human biology. I think in the end, we use the same processes dependent on the different situations and have different outcomes. The issue with stem cells and migration, Mike didn't mention this, but it's an interesting, just true, real-life Mother Nature experiment. So is there any evidence that embryonic-derived stem cells that we do nothing to, that just exist, can actually repair on their own human tissue? And the answer is yes. So it's actually kind of a great Hallmark commercial. So for women who have been pregnant, who've had children, you can look in their blood for years, and even up to, I think studies have gone 20 years, and find evidence of fetal-derived stem cells from their child circulating in their bloodstream. Okay, so for all the moms in the room, it's true, you carry your children with you for the rest of your life. And whatever guilt goes on, it's the same thing. But
that's why you need repair, buddy.
That's why you need repair. That's exactly right. So what's interesting is if you look at moms who have had certain injuries, so if you look at a mom who's had a heart attack, if you look at a mom who's had hepatitis, there is data both in mice and in humans to find cells that were of fetal origin in the liver making new liver cells. And so this idea of the big question that's been posed in the debate about embryonic stem cell work and will it work and is there a model to prove that it's actually functional, I think actually that's one of the best pieces of evidence to say, at least in a natural setting, there is data to say that these cells can go in and repair and be functional and helpful. It's never been proven in transverse myelitis, NMO, or multiple sclerosis. We've never applied that paradigm to see if women who have given birth to kids have more repair or not. But it's an interesting piece of data. So, other questions?
In In the dinner talk last night, they were mentioning that interferon beta might actually make the condition worse if it happens to be not a typical multiple sclerosis. Is glatiramer also known to make the disease worse, and should we be suspecting, if the patient is not responding to any of the standard treatments, that it is not typical MS?
Mike, do you want to jump in?
Yeah. I have had patients with neuromyelitis optica come in, diagnosis of MS, on Copaxone. And it's not harmful like beta interferons, but it's not helpful either. And so really, I consider them untreated if they're on Copaxone. And if I'm convinced they have NMO, I switch them to a better treatment for NMO.
Next question.
I kind of switched back and forth between the two rooms, and the other room had stated something that when you have a NMO attack and you go to the emergency room, that they should start steroids immediately, then plasmapheresis. And what I was wondering, if you're giving somebody plasmapheresis, aren't you giving them back like the B cells, and that would cause them to go into a further attack? Or would you follow up real quick with rituximab?
So we don't really know exactly how plasma exchange works, but it works really well with NMO. And you're right, we don't take the blood cells out, the B cells or T cells or any other cells, but we do take out a lot of antibodies and a lot of other cytokines that may be harmful. And for whatever reason, it may be that that combination just works really well. There are other groups in Japan, for example, that they don't take out the entire plasma, they take out selective parts of it, some white blood cells, some antibodies, and they're trying to be more selective. And so we'll see if they have any luck in figuring out exactly what components of the plasma we should be removing.
So would you just follow up with the rituximab real quick?
I do try to get the Rituxan in as quickly as possible, but only for preventative care, not for acute treatment.
Okay. Next question.
Regarding TN, is it beneficial to have a second IV steroid treatment if you haven't had a marked response to your first treatment?
So I'll throw that one to Ardith.
Oh, great.
Yeah,
You know,
exactly.
thank you.
You're welcome.
I'll remember that. So I think that kind of falls into the individual case, meaning that it really does depend on what's going on and what the lesion looked like in the first place. And so I think sometimes, even though I may not have good scientific basis for things, sometimes I just feel the need to do what I can. So even though you know, there may not be a good basis for it, I may go on and give a second course or extend the course that I originally used. But I don't know that there's any great support for that.
And I'll refine your question a little bit just to get thoughts, and that is, how does everyone individually decide how to escalate therapy? So regardless of what it is, whether it was steroids or something else, if somebody's in the throes of an inflammatory attack, are there any general rules in terms of what should or shouldn't be done? And I know, Greg, we were talking about this a little bit. I don't know if you want to chime in.
Well, in general, what I do with an acute attack is that, you know, if I don't see a marked clinical response within, 48 to 72 hours after starting the steroids, then I start thinking about escalating therapy, and I don't know what the other people in the panel do. Why don't you chime in with your thoughts, because I thought you had an interesting view of this.
Yeah, I may be on one end of the spectrum. So in general, and I'm curious if this is an accurate statement, I think for 95% in the United States of transverse myelitis patients, the therapies that are discussed are steroids, IVIG, plasma exchange, cyclophosphamide. There are probably others, and everyone's used a different combination, but those are probably the mainstay four. And everybody gets steroids. There hasn't been a trial in the history of man of transverse myelitis. There hasn't been a retrospective study where somebody hasn't gotten steroids. Have we ever done a blinded trial of steroids and transverse myelitis? No. And so it's left over, and it's one of those things in medicine that we just can't seem to let go of. We have reasonable data to say it's helpful, actually pretty good data to say it's helpful, but we also know it's not helpful for everyone. So the real question in my mind is, what do you do when someone's not responding to steroids? And I think the biggest battle is over IVIG versus plasma exchange. And we're hoping, and Michael and I and Dean and some others have talked about this for a while, trying to get a head-to-head trial of IVIG versus plasma exchange done. Everyone should give their own experiences. Mine are, I've been very disappointed in IVIG relative to plasma exchange when it comes to acute attacks in transverse myelitis. And so we, in the Dallas area, we've moved almost exclusively, not exclusively, to plasma exchange in preference to IVIG. We're getting there. There are individual cases that make a difference. Cyclophosphamide we tend to use, especially if we know certain things about the patient. So if somebody comes in and they have a rheumatologic condition, so lupus or Sjogren's, and they're having transverse myelitis, Cytoxan, I would say, by far is the indicated drug, more than plasma exchange or anything else. Just like in neuromyelitis optica, as Mike was saying, plasma exchange works. It works probably better than any of the other drugs. And so if you're an NMO patient coming in an attack, it's pretty hard for me not to exchange you. And so that's where we're moving here. I don't know if people
I'm actually going to pipe in because I was out in practice for a while, and so I'm now at the university, and I used to treat patients with Guillain-Barré, which is another devastating neurologic condition. And I think the same controversy kind of went on. You know, we do the steroids, and we don't do the steroids, but we do IVIG and plasma exchange. And it kind of depends on where you're at. Now, I'm at the university. We have a great service. There are risks to that procedure, and I feel totally comfortable ordering it at the hospital I'm at now. But if you're out somewhere and plasma exchange is not regularly done, then maybe IVIG may be better. And that's where the individual, you know, questions kind of come up from what's going on, I think.
Yeah, and it's a great point. I'll phrase it one way and Adam chime in, but it's, so it begs the question, because I think there's no data for this, but in NMO, for example, I'm much more convinced by plasma exchange for an acute attack than IVIG. And so one of the questions I've been asked in the clinic, and everybody should chime in. So let's say you're an NMO patient in a community that doesn't offer plasma exchange, and you're having an acute attack. Is it worth it to actually be transported to somewhere that offers plasma exchange? And I'll withhold my answer and let you guys go, but Adam, I'll let you.
Yeah, so I happened to, at breakfast this morning, be sitting at a table where I was eavesdropping on some parents talking about how difficult it was because they may have been in a place where their doctors didn't get the diagnosis right, or they didn't know what the treatment was. So here, it's just sort of ironic to hear how many different opinions there are among the experts. So from the morning discussion, you can imagine how much more difficult it is for people in the field these are the world experts here. And if there's no consensus here, then the answer is we don't know yet. But I think that the important points are, one, that Ben raised, that there are, you know, a short list of treatments that should be put out there. The other thing I'll tell you is that Kristen, Ron, and I are trying to take a tact, which is a very long perspective, but we are trying to get a drug company interested in getting TM as an indication for their new drug. And if you can get a pharmaceutical company out there to buy into the idea that this is a rare disease, that they can get it, pharmaceutical companies will spread the word far and wide. But that's going to take years because we're doing preclinical studies right now and it might not work. So then the issue comes back to one that I know you were working on, Doug, and I'm just curious to raise it for you, Ben, and the other members of the panel. You know, for the families who are out there and future families, is there a way to get the word out to the emergency rooms, to doctors? Is there an effort to sort of get the word out to people on the front lines? Because this had been sort of something that had been discussed previously. So I'm just curious about that.
Yeah, so there's a couple of us putting in, and this is something we've talked about for a while, and we're submitting to the American Academy of Emergency Medicine Physicians to be on their annual meeting for presentation on neurologic emergencies.
That'd be great.
So we're trying,
That'd be great.
we submit the proposal and we wait to hear if we're invited to speak and have a little section on transverse myelitis.
That'll make a huge difference.
Okay, we'll start in the back and then we'll move to the front.
On your website, on the transverse myelitis website, is there a information for physicians that anyone, when they go to the emergency room, can say, I don't really know what I'm supposed to do, but I know you should click this thing because it's going to tell you what to do in an emergency?
Yeah, it's Sandy's home phone number.
Well, well, this is a serious issue.
It's a very serious question.
It's a very serious question.
Because, this organization is slightly modeled after the FOP organization. I can tell you that the FOP organization has a complete PDF compendium of stuff that doctors need to know. And if we don't have that now, it shouldn't be Sandy. It should be an effort. We should undertake the effort to document what ought to be known, and it should be updated.
So, I mean, so if you click on, so the two top links on our website are about acute therapies, that's the top link, and the second link down from that is about transverse myelitis. If you click on about acute therapies, what you get is a link to every physician presentation that's been done over the last 4 or 5 years on acute therapies, and Ben's article that was published in Neurology that identifies this retrospective study of 200 patients and what kind of outcomes the patients had depending on how they presented, what kind of outcomes they had depending upon whether they got steroid and Plex versus steroid and cyclophosphamide. It's the only study that has been done to my knowledge, and so that data is there. And then if you click on about transverse myelitis in big, bold, red letters, it says print out these articles for your loved one to go to the emergency room. And it's articles that were published by the Johns Hopkins TM Center that are sort of overviews of transverse myelitis, including discussions of acute therapy.
It is worth noting, because it's a very good point, Chuck, that it is working. And so there's not a week or a month that goes by that I don't get an email or phone call, and I know it's the same for half the panel, for people both in the throngs of an attack, and it's not just family. I'm getting more and more phone calls from physicians who have identified the literature, residents who have admitted a patient in some hospital, and they do their literature search, and they're reaching out. So it's working. I think your point of coming up with a guide would, and I'll raise this to the panel, it is probably time, so that the diagnostic working group that was put together by you, Doug, years ago to come up with the nomenclature for transverse myelitis. The question is there enough evidence yet to justify bringing on a panel for a position paper, because that's the way to do it, on what to do for therapeutics? And I don't know if you have a comment on that, Chuck.
I would suggest, so I'm a physician.
It's on.
And if I need to make a quick decision, I don't want to read an article. I'd much prefer basically a consensus panel. These algorithm, clinical pathway, this is what we do as of 2010. And it can be updated periodically. It can also be put in print, but again, if someone's in an acute state, I'm not confident that the ER guy is going to read the article. Maybe I'm wrong about that. But anyway, that's my comment.
No, I think you're right, Chuck. And you know, when we published that 2002 paper on the classification of transverse myelitis, there were tables, but there was also a very important algorithm. And it basically says, patient comes in and their spinal cord isn't working, what do you do? And then you find this, and if it looks like this, you go this way, and so on. And so basically any physician can work down that tree and decide, okay, this is or is not transverse myelitis, and if it is, what type? Is it associated with lupus? Is it NMO? that type of thing. So that was 2002, and it stopped there, and it was very helpful. But since then, I think Adam and Ben published basically an addition onto that. And I don't know where that algorithm is, but basically it then says, okay, so you get here, now what do you treat? And it suggests really steroids, plasma exchange, IVIG, cyclophosphamide. I forget where that came out, but I think you're right, that very prominently positioning that as kind of the first link off of the TMA website would be something that they would look at quite quickly.
One of the problems is that flowchart is like on the 6th or 8th page of the article.
Right.
Yeah,
But
there
you
should
put
be
it
an
front and center.
individual PDF.
So you have to get interested in the article before you get to the
Right.
flowchart.
Yeah.
Like figure 6 and
Yeah.
the way it was published.
Yeah, we should just extract that flowchart and put that as a separate thing.
Right,
Then
That's a
make
good
it-
idea.
both the diagnostic one and the,
treatment.
what do you do from here, the
Yeah.
treatment one.
I don't remember where it came out. Does anybody remember where
It's neurology.
the most revised version of that? Anyway, we can find it. I don't know.
Yeah.
I actually have two questions, so bear with me. The first one is, given the fact that no one really, I mean, I've heard it said that no one really knows why plasmapheresis or plasma exchange work. Is there any benefit to patients after their acuteness? So is there any benefit to doing plasma exchange during the rehab recovery?
So I'll take a shot at it. I mean, a couple things about plasma exchange. We all agree it's effective. A couple papers, including one by Brian Weinschenker and one by Ben, gave us a fairly sobering reminder that for those who are completely injured, so for the most severe transverse myelitis, those for whom there's no movement, no sensory, no bladder, the plasma exchange didn't particularly help those people. And in fact, in Ben's series, those patients who were completely injured actually responded to cyclophosphamide, one pulse of cyclophosphamide, although they didn't respond to plasma exchange. But more directly to your question was, would you consider it outside the acute phase? The way I think many of us will think about it is we'll evaluate the patient, and if there's any evidence of ongoing inflammation, and there's a recovery that isn't proceeding as fast as we'd like, we're going to look at the options to continue that treatment. So, as opposed to kind of a one-off, okay, here's your steroids, go away, hope all is well, it's the kind of thing where you really need to continually reevaluate. So, if there's still gadolinium enhancement on the MRI, if the spinal fluid is active, if there's some serology or blood studies that suggest an autoantibody or something like that is still present, or some evidence of a systemic inflammatory process like lupus, by all means we would. In the absence of that, if it all looks quiet and you're months and months out, at that point you're probably inducing more risk than potential benefit, because there are risks to plasma exchange.
So I'll just make two quick comments and then turn this question over to Maureen, because she has experience with this. So one is we're working on the paper right now as a supplement to the first one to make the note that plasma exchange, the time to plasma exchange may be a significant factor in whether or not you respond. And we're gathering the data right now, which is not easy to do. But when we did, so the paper we did in 2007, which was great to get experience out, it's a retrospective paper. So some people got exchanged 30 days out, some 15 days out, some longer. And so it's a mixed group, and there wasn't enough in there to really say, if you get exchanged within 48 hours, 1 week, 2 weeks, does that time course make a difference? I'm starting to get the sense that it does, and so there may be a revision of that. One thing in terms of your question, though, is I break it down into two groups. So one is people who are a few months out versus years out. And I know Maureen and I have shared patients who have been more than 60 days, 90 days, somewhere in that range out, where they had gotten steroids for their event, hadn't responded, and the big question was, do we bring them in to exchange? And I'll let her comment on that. In general, if I think you're more than a few months out with no evidence of inflammation, I don't think anyone's seen a benefit. But Maureen, I know you've had patients with this.
Well, and actually, Dr. Levy has a patient who was optic neuritis,
optic neuritis 9 months out and got exchanged and actually did have a benefit from being exchanged 9 months out from her acute attack.
But she still had evidence of inflammation. But she did. And let me just add one thing. There was a paper out of Spain that looked at patients with transverse myelitis who got exchanged 5 times, 7 times, or 10 times, so essentially twice. And it made no difference. So the ones who responded with 5, 7, or 10, it made no difference how many times beyond 5.